Greetings from the United States. I'm Dr. Pablo Stolovitzky, International Coordinator and member of the Board of Directors of the American Academy of Otolaryngology Head and Neck Surgery. And on its behalf, I'd like to congratulate Professor O'Donoghue, BACO 2020 Master, Professor Mehana, Program Chair, and Professor Nirmal Kumar, President of ENT UK, for this excellent virtual Congress. I appreciate the invitation to participate. Following the excellent presentation by Dr. Lisha McClellan on acute rhinosinusitis, we're going to follow a similar pattern where we are going to discuss chronic rhinosinusitis, definitions, classification, diagnosis, and management. And we're going to base most of this on the latest publication by EPOS 2020. ICAR 2021 was published this week of the recording, and we will not be discussed at this presentation. As we know, chronic rhinosinusitis in adults is defined by two or more symptoms that include either nasal blockage and obstruction, congestion or nasal discharge, anterior and posterior nasal drip, with or without facial pain and pressure, with or without reduction of smell. The symptoms should last more than 12 weeks. Now, when we base the diagnosis of chronic rhinosinusitis exclusively on symptoms, our prevalence reported had been between 5.5% and 28%. But when we add additional criteria, including CT scan and endoscopy, the diagnosis now prevalence is reduced to 3 to 6%, which means that it makes it more specific in terms of diagnosis. Therefore, the recommendation is to not only base this on symptomatology, but also include in it the evidence of nasal endoscopy and scan. Now, a lot has been said about phenotypes and endotypes. The definitions that we're going to use is that a phenotype is an observable clinical characteristic with no relationship to a disease process. For example, acute allergic fungal rhinosinusitis symptoms will have certain symptoms, and they are associated with certain endoscopic and CT findings, like nasal polyps. When we talk about endotype, this is a distinct disease entity defined by a specific pathophysiological mechanism, like inflammatory parameters. We're going to discuss quite a bit today about IgE, interleukin-5, for example, and eosinophilia. So phenotype and endotype, and we're going to use this quite a bit. So a phenotypic classification of chronic rhinosinusitis will be chronic rhinosinusitis with polyposis and chronic rhinosinusitis without polyposis. So this is the phenotypical definition and classification of it. Now, chronic rhinosinusitis is a syndrome, and that means that we have multifactorial etiologies resulting from a dysfunctional interaction between the environmental factors and the host immune system. So let's remember this dysfunctional interaction, and we're going to discuss further how they relate to the diagnosis. But the intensity and nature of the endotype plays a key role in determining the observed phenotype. And so you see, when you have more eosinophilia, like in this, the phenotypic presentation is this will be expected to have significant more polyposis and allergic mucin. And there is a big range of presentations based on what the endotype is. This slide illustrates a contemporary model of chronic rhinosinusitis pathogenesis. As we mentioned, there is a dysfunctional interaction between environmental factors and the host immune system. When the barrier is penetrated, an immunodefensive response is generated, endotype, with resultant chronic inflammation leading to tissue remodeling and clinical symptoms, phenotype. The sinonasal tract is covered by ciliated pseudostratified columnar epithelium that plays a critical role in host defense. Host defenses are grouped under innate immunity, which provides immediate protection against microbial invasion, and adaptive immunity, which provides a delayed but more specialized defense against infections. This cellular response with cytokine production leads to tissue remodeling, polyp formation, and fibrin deposition with acanthosis and desquamation. Physiologic immune responses across mucosal barriers are tailored to address particular classes of pathogens. Type 1 responses are directed against intracellular pathogens, most commonly viruses. The response is mediated by the innate lymphoid subset 1, or ILC1, that rapidly produces the canonical cytokine interferon gamma. ILC1 is linked to corresponding delayed T helper subset 1, or TH1. Type 2 responses are directed against large extracellular parasites. The response is mediated by the innate lymphocyte subset 2 that rapidly produces IL-4, IL-5, and IL-13. ILC2 is linked to a corresponding delayed response by Th2 cells. Type 3 responses are directed against extracellular bacteria and fungi. IL-3 rapidly produces IL-17 and IL-22 and is linked to a corresponding delayed Th17 cell. We're mostly going to discuss today type 2 response to inflammation. This is the proposed model of type 2 immune response in chronic rhinosinusitis. ILC2 cells and dendritic cells set the process in motion. Th2 cells induced by parasitic infection secrete IL-4 that promote IgE and IgG4 production, mast cell degranulation, and eosinophil recruitment and degranulation, causing edema and mucus production. IL-5 promotes eosinophil recruitment and degranulation, contributing to edema formation. Now, barrier damage in type 2 chronic rhinosinusitis is often severe, and this may be a key driver of treatment failure. IL-13 contributes to mucus hypersecretion, barrier breakdown, and fibrin mesh degradation. So how do we translate this into our clinical practice? So it's important to determine if our patients with chronic rhinosinusitis present a type 2 response or a non-type 2 response to help us in our decision-making clinically. So one of the parameters that have been used in terms of definition of type 2 response in a clinical practice is the eosinophil count per high power field, that is more than 400 magnifications, should be 10 or higher per high power field. And if we looked at blood eosinophils, they should be higher than 250. This points out to type 2 response or type 2 endotype. When we look at allergens, the gold standard of the upper airway allergy is a skin prick test that will define what our patient has in terms of allergies. But another important parameter, as we saw in type 2 inflammation is that the serum IgE will be elevated. So a patient that has a serum IgE equal or more than 100 shows evidence of type 2 inflammation. So those are the three things that we should order for our patients in terms of trying to get to what type of endotype the patient is belonging. And of course, the olfactory function that is important, particularly during the era of COVID-19, can be done by different means. One is the North American University of Pennsylvania test, and the other one is the European Sniffing Sticks test. Both will guide us to the process of what the patient olfactory function is, whether they're having hyposmia or anosmia or its normal function. So let's look at the classification that is being adapted from Grayson et al. by EPOS 2020. So one is the primary chronic rhinosinusitis diagnosis. And the proposed anatomic distribution to use is either if it's localized, which usually is unilateral, or if it's diffuse, that means bilateral and throughout the sinuses. So with that anatomical classification, we're going to go further with the endotype dominance that we will define based on the clinical parameters that we just discussed. So is this patient having a type 2 dominance or is a non-type 2? Now, a type 2 localized will be, for example, allergic fungal rhinosinusitis. That will be the phenotype. While a localized non-type 2 response will be an isolated sinusitis. Now, let's look at the diffuse or bilateral primary chronic rhinosinusitis. Again, the endotype dominance could be type 2 or non-type 2. If it is type 2, an example of phenotype will be chronic rhinosinusitis with nasal polyps or eosinophilic chronic rhinosinusitis. Allergic fungal rhinosinusitis will be another, and central compartment allergic disease will be another example of this. A non-type 2 will be a non-eosinophilic chronic rhinosinusitis, and again defined by the parameters that we just discussed. This is the classification based on anatomic distribution, endotype dominance that will give us the examples of the phenotypes. Now, secondary chronic rhinosinusitis can also be divided by a localized anatomical distribution or a diffuse anatomical distribution. And again, if we look at local pathology, something that is very, say, maxillary sinusitis, could be related to an odontogenic sinusitis, a fungal ball, or a tumor. These are examples of secondary chronic rhinosinusitis that are localized. While diffuse or bilateral secondary rhinosinusitis could have a mechanical endotype dominance or could be an inflammatory dominance. For example, the granulomatosis with polyangiitis is an example of that. Immunity, for example, a selective immunodeficiency will also lead to a chronic rhinosinusitis that is secondary to the immune system deficiency, that it will be diffuse. So these are the examples of classification that we have to pay attention. And I think that this framework will help us start analyzing not only the endotype, but also the phenotype, not only the phenotype, but also the endotype. So what are the recommendations in terms of management of chronic rhinosinusitis? We're going to look at some definitions. What is considered appropriate medical therapy? In terms of antibiotic course, a short term of antibiotic therapy will be less than 10 days and usually used for significant acute bacterial infection, meaning somebody with chronic rhinosinusitis develop an acute exacerbation. Therefore, the treatment is directed by culture direction, and it's used for about 10 days. Long-term treatment of chronic rhinosinusitis is defined for more than 4 weeks of treatment, and usually is not used for antibacterial properties, but rather for their immunomodulatory properties. Examples of that is the use of macrolides, most commonly used as immunomodulation for non-type 2 rhinosinusitis, and doxycycline that has also been proposed as an immunomodulator for type 2 chronic rhinosinusitis. Functional endoscopic sinus surgery or functional sinus surgery is the preferred for non-type 2 endotype. That means that we are just creating a sinus cavity that incorporates the nasal ostium, and we just do our surgery that is related to very conservative to facilitate mucociliary clearance, to allow for instillation of topical therapy, and allows for adequate ventilation of the sinuses. And again, this is more of the conservative side. Now, when we're looking at the preferred surgery for type 2 endotype, we're talking about full FES or so-called extended endoscopic sinus surgery. And we're talking about complete sinus opening, including anterior and posterior ethmoidectomies, large middle meatal antrostomies, including megaantrostomy, large sphenoidotomies, and extended frontal sinusotomy, a draft 2A, B, or a draft 3. And this allows significant exposure of all the cavities. That is the preferred surgery for type 2 endotype. We're not going to get into the details of surgical technique because it's beyond the scope of this presentation. But basically, this is the framework as to where endotype fits into our daily activities in terms of management of patients. So this is the proposed management of diffuse chronic rhinosinusitis by EPOS 2020. So this is particularly for us specialists, otolaryngologists, rhinologists, etc. Again, we define appropriate medical therapy as the use of nasal steroids, either in drops, sprays, or rinses. High volume rinses is my preferred methodology. The saline rinses have a type 1A level of evidence. And it's important that when we do this, that we educate our patients on the technique, how to do it. And then we will consider the use of oral corticosteroids in the event of more severe type of sinusitis. So we do this and treat the patient anywhere between 6 to 12 weeks, and then we check for improvement. If there's no improvement, then we will proceed with this algorithm that will include additional workup. In that case, we will proceed with a CT scan, a skin prick test, lab work that, like I said, looking at IgE, immunoglobulins, IgE, look at the eosinophil count, and if we have any biopsy, to look at the number of eosinophils for high power field. And then we'll also assess the compliance of the patient with the treatment. If we label the patient as non-type 2, which main complaint is often nasal discharge or some facial pain, but not much atopy, not much asthma. And by nasal endoscopy, we see purulence, and we have a normal IgE, we have no eosinophilia by lab work. Then the recommendation would be, as appropriate medical therapy, to do long-term antibiotic as an immunomodulation, or the other option would be to offer the patient a limited or functional endoscopic sinus surgery, just to alleviate the symptoms. Now, we look at this and look at 6 to 12 weeks and see if there is any improvement. Of course, after FES, patients should continue with rinsing and everything that we do for them with either steroids in the rinsing high volume, the need of long-term antibiotic if necessary, and offering other things if the patient is considered to have a secondary diffuse chronic rhinosinusitis, like a vasculitis or immune disorder. So what happens if we complete our additional workup and we conclude that this patient has type 2 endotype? So the main complaint of them usually is smell loss or significant congestion and blockage, and they have atopy and they have asthma. And on nasal endoscopy, we'll see polyposis or eosinophilic mucin, and the lab work will reveal an elevated IgE, eosinophilia in blood, and if we do tissue biopsies, we will see high power field eosinophils. So in that event, we use appropriate medical therapy with or without oral corticosteroids, depending on what we decide. And then we'll include an extended functional endoscopic sinus surgery, which will, if we do that, open all the sinuses with the intention to deliver topical therapy and alleviate the symptoms. Again, we continue to follow the patient for a long period of time. These patients, I tell them, you're going to be here for life because we can't cure your condition. We can definitely manage that and make you improve your quality of life. So additional therapy considered for these patients will be biologicals, also aspirin desensitization, taper doses of oral corticosteroids, or if necessary, revision surgery. So we're going to concentrate now on the biologics and where do they work in this inflammatory cascade. So when we look at dupilumab, for example, that's an anti-IL-4, which will allow for decreased IgE and decreased mast cell degranulation by shutting off that cascade. Omalizumab is an anti-IgE, and that will be doing a similar thing in terms of decreasing the IgE and the mast cell degranulation. Mepolizumab and reslizumab are anti-IL-5, and they are now involved in the eosinophilia reduction, and they do that quite effectively. And benralizumab, which is actually a reduction by blocking the eosinophils. So these are basically the ones that are now being tested and some in the market. We're going to talk some about the indications. When are we going to do biologics in patients with chronic rhinosinusitis with nasal polyps? Say we have a patient with bilateral polyposis and the patient had endoscopic sinus surgery. So 3 criteria are required to indicate them. 1, the evidence of type 2 inflammation, again defined by tissue eosinophil of more than 10 per high power field, or blood eosinophil of more than 250, or a total IgE of more than 100. Need for systemic corticosteroids or a contraindication to using systemic corticosteroids. So more than 2 courses of corticosteroids per year, or the need to use long-term corticosteroids, say more than 3 months, are indications that meet criteria for the indication of biologics. We look at the SNOT-22. A SNOT-22 equal or more than 40 is affecting significantly the quality of life of this patient. The other consideration is the patient anosmic or is hyposmic and how significant the impairment is. And then the diagnosis of any comorbid asthma and how much inhaled corticosteroids the patient needs with their asthma. So if we have 3 of these 5 possible criteria, we have a good indication for the use of biologics. And that's when we're going to indicate them. Now, dupilumab has been approved and is currently being used. These are some of the studies by Professor Bashert that did and published these studies. It's a Sinus 24 and a Sinus 52. And this forest plot shows the effect of dupilumab versus placebo, and it favors dupilumab over placebo in terms of relief of the primary endpoints. Now, this is the graph of the decrease in symptoms by dupilumab. As you see that over the period of the 24 weeks that the patients were followed, there's a significant change in bilateral nasal polyp scores, for example. And then at 24 weeks, the dupilumab is stopped. And that's when, of course, it's expected that some of the symptoms and some of the polyps will start reoccurring to a certain degree. So the effect of these biologics are there when we use them, and obviously, like everything else we do, once stopped, they decrease their effectiveness. And this is some of the other studies that have been shown the effectiveness of dupilumab. So EPOS 2020 advises the use of dupilumab in patients with chronic rhinosinusitis with polyposis that fulfill the criteria that we just discussed earlier for monoclonal antibody treatment. Now, anti-IL-5 like mepolizumab and reslicumab are also advised to use in patients that are fulfilling the criteria for the treatment of monoclonal antibodies. And here you have the forest plot with the effect of the anti-IL-5 biologics and how they improve the symptoms in patients that are using it. So now we're going to see how long would you use the biologics. So one of the recommendations by EPOS is to follow the patients over a period of time along the lines of these 5 criteria, which is the reduction of nasal polyp size, the reduction of the need for systemic corticosteroids, the improved quality of life, the improved sense of smell, and the reduction of the impact of the comorbidities. So this patient, if you have 5, that's all 5 criteria met, that's an excellent response. If you have 0 criteria met, say you reevaluate the patient at 16 weeks, and then you do it again after a year. If the response is 0 or near 0, the recommendation is to discontinue the treatment because no response means that it will not be worth continuing. So these are the guidelines for the use of biologics. So in summary, we reviewed the evidence-based of the chronic rhinosinusitis guidelines. We look at the recommendations and we use the EPOS 2020 integrated care pathways. We presented the new classification recommended by Grayson and adopted by EPOS 2020 on chronic rhinosinusitis, where we talk about primary and secondary, localized and diffuse disease based on anatomical distribution. And we describe the inflammatory pathways or endotypes at length about type 2, and we learn how to define non-type 2. And discuss the use of biologics in the treatment of type 2 chronic rhinosinusitis. And with that, I thank you so much and have a wonderful meeting. Appreciate it.